Hello, and thank you for joining us for this session to support this evening's theme of implementing pathways to enhance wound healing. We've heard how clinical protocols and pathways are effective tools to assist with clinical decisions to identify the most appropriate wound management. And within our session this evening, we'd like to place a lens over the important role effective exudate management has to play to support best outcomes. My name is Rachel Torkington-Stokes, and I'm the Global Medical Affairs Director for Advanced Wound Care here at ConvTech. I'm delighted to be joined by Lindsay Downing, a specialist podiatrist in diabetes and wound care. Lindsay has over 20 years experience in podiatry and has spent the last 6 years dedicated to the management of complex wounds. Welcome, Lindsay.
Thank you very much. Thank you for having me.
It's a pleasure. So Lindsay, first of all, would you mind telling us a little bit about yourself? And I guess the big question is your background and what interested you and got you into wound care.
So as you said, I'm a podiatrist. I've been qualified for sort of over 20 years now. I work exclusively within diabetes and wound care in the community. So I work in a community clinic. We do wound care patients most days of the week, and if I'm not doing patients, then I'm usually doing something else to do with diabetes. So I'm a diabetes educator as well outside of clinic. So pretty much 100% of my time will be given over to wound care and diabetes. I think I got into diabetes initially through the education role, and then through that became more involved within the wound care clinics, obviously educating people about the long-term effects on their health of diabetes. You kind of get more and more involved, and that led me to becoming part of the wound care team that we've got where I'm based.
So we know that global wound care is in crisis. There's a burden of these hard to heal wounds, of which diabetic foot ulcers are very, very common globally. Could you outline the burden of diabetic foot ulcers, how and what they impose on patients and their families or carers?
Yeah, so the burden on patients and their families can be quite great, really. Thinking about the patient initially, if you're thinking about those sort of psychosocial factors that go along with having a chronic wound, there's the repeated visits to clinic for wound dressings. It's quite costly with regards to time. We have a lot of younger patients now as well. So those younger patients are needing to take time away from work, which can be slightly problematic for some of them. With having a wound, a chronic wound, you can have issues with things like odour, you can have exudate problems, wounds can be leaky, leak through their dressings. So dressings can shift and move, and patients can be very conscious of having those dressings in place. If a patient is offloaded, which is something that we do a lot with diabetic foot ulcers, obviously you've got something very visible there that's drawing attention to that foot and the fact that the patient has an issue. Thinking a bit more widely around sort of the families or the carers and the impact on them. The patient themselves may not be particularly mobile, either because they've got mobility issues or because they're offloaded, so they might rely on families to bring them to clinic. So there's that impact on time with the families as well, with the care of the spouse, brother or sister who's bringing them to clinic. Again, if you're thinking about patients, not necessarily younger patients, maybe patients with grandchildren, if you're asking them to stay off their foot, to wear an offloader, to sort of take that, you're asking them to take that time away maybe from their normal activities, so they're not able to go and walk the dog, take the kids to the park. It can have quite an impact on their personal relationships at home. As well as that, if you're asking a lot of your family members or your carers, you can feel a little bit burdensome, and we do know that patients feel a little bit like that. They'll speak to us about it and feel that they're sort of putting upon their family members, a lot, so that there's this kind of the stress and worry that comes along with that as well. I think the other thing to sort of say really about diabetic foot ulcers is that we know they can go from being relatively kind of stable, maybe look like they're deteriorating slightly, and they can really rapidly deteriorate, and that patient can get quite poorly quite quickly, and that's difficult for families. Sometimes you've got a patient who's attended clinic and is fine, and then they come again 2 days later and you're having them admitted to hospital. It's quite frightening. So there's that kind of that level of stress that goes alongside it as well for those family members. You know, we've had patients that have sometimes had to change holiday plans, cancel holidays, been on holiday, not been able to do the things that they want to do when they get on holiday. So, you know, the burden from the sort of personal perspective for the patients and their families, you know, it's quite significant, really.
So it's clear to see from what you said about the huge impact to these patients and their quality of life. And I think when we think about the size of the problem, you know, we often talk about the rule of 15, that 15% of patients who have diabetes will go on to have a diabetic foot ulcer in their lifetime. And 15% of these ulcers will also go on to develop osteomyelitis, and we know the complications and outcomes from this. And sadly, we often see that 15% end up being amputated, which is a huge cost to those patients that you've talked about, particularly when we know they are of a younger generation. And when we think about the UK as well, that 9,000 people undergo a leg, foot or toe amputation each year, which is equivalent to 176 per week. Very strong statistics, which evidently show us how challenging these wounds can be. So, Lindsay, when we think about the wound challenges from a wound-centric perspective, and you as a podiatrist implementing wound care, what would you say are the main challenges?
So from a podiatric perspective, the challenges are the wound on the foot, so the placement of the wound. So we know that in people with diabetes, they can often have that kind of fixed flexion deformity of their foot, so it creates some really high pressure areas. When you've got those high pressure areas on toes, they can be quite tricky to dress. And if you're looking at placing a dressing underneath the foot or around the foot, getting it to stay put is quite a challenge. Excuse me. So when we're thinking about sort of dressing our patients' feet, we use taping quite a lot. So we'll use a hypoallergenic tape to secure the dressing to the foot. We'll need to really think about good exudate management with foot wounds. If you're using a really good absorbent dressing, but then your patient stands on it, that dressing can be like a sponge, so all the exudate, which you're really wanting to pull away from that wound because of the harm it can do, that exudate kind of spreads out from the dressing and back into your wound. So we really need to think about a dressing that's going to withstand that pressure that the foot's putting on it. Hold the exudate where we want it to be, so it's not damaging the wound further or that peri-wound area. In URI, if we have a wound on our foot and we stand on it, we know that it's there, it's painful. In a patient with a diabetic foot ulcer, you can probably guarantee that they've got some degree of neuropathy, which is how the wound is developed in the first place often. They don't know that they're standing on that wound, they're causing more damage to that wound, they can be damaging the dressing that's over the top of the wound. So they're not altering their gait or their stance or where they're placing their foot down. So again, you're putting more forces through that wound, friction forces, direct pressure. So in those cases, then we'd look at offloading the foot, so offloading the wound, sorry, so that we aren't, subjecting it to that amount of force. You might use something as simple as an offloading sandal. So you're offloading a forefoot or a heel wound with one of those devices, the sort of most simple. We've usually got access to them in clinic. A bit more effective than that, I suppose, would be something like your Pegasus systems, the sandals that have got the Pegasus insoles in them, where you can really direct that offload into where you want it to be. And then obviously we'd be looking, ideally, your gold standard, your sort of total contact casting or the total contact systems that are now available to offload that wound really effectively. So in doing that, you're protecting the wounds, you're protecting the dressing, allowing that dressing to do what it needs to do in order to promote healing with the wound on that patient's foot.
So you've clearly outlined a significant number of factors that are very important when managing these patients with these ulcers. And to drive effectiveness and embed real change, protocols clearly have a strong role to play. So within your approach and your care setting, what factors do you consider when choosing an appropriate dressing for patients with a diabetic foot ulcer?
So we'll look at a few factors really. So initially you'll look at your wound type, the wound size, the wound site. is the wound infected? Do you need to be using an antimicrobial dressing? Do we need to factor in offloading as well? You know, what can we do that's going to best promote healing in that wound? In thinking about that as well, from the patient's perspective, we want to try and kind of minimize the impact on the patient. So you want a dressing that is going to, you know, maybe require fewer dressing changes. In that way, you'll help with your patient concordance as well. So, as I mentioned, you know, one of the issues with the wounds under the foot can be with exudate management. So, I think in the past, we've maybe gone towards thinking, oh, this is a really heavily exuding wound, we need to be looking at antimicrobials, but actually what we need to be doing really is managing just that exudate that's coming out the wound. We need to be getting rid of that harmful, you know, fluids that's really disrupting the surface of the wound. It's really damaging the skin around it. So that's where, you know, the super absorbers like your ConvMax are really useful. I found in my practice that ConvMax has been a great dressing to use on the foot. It comes in a variety of different sizes. It comes in some smaller sizes and also some more rectangular sizes, which are really good for wrapping around kind of an awkwardly shaped foot. It's also proven to be quite robust. So some of our patients, I mean, particularly for my patients that are coming to see me in clinic, obviously they're ambulatory, and those ConvMax dressings really stand up well to the pressure of being walked on by the patient. The exudate holding capabilities is good as well. So when you've got the patient standing on it, it's not kind of going out everywhere, it's staying put. You can use a primary dressing with it underneath if you do need that antimicrobial, but ultimately, you know, to me, they've been a really good way of managing the exudate and really promoting you know, the peri-wound area, keeping the peri-wound area healthy and keeping that skin sort of nice and robust.
Thanks. And I think, as you mentioned, you know, these ulcers being on the foot, the anatomical location is a challenge. The neuropathy is a challenge because obviously with bulky dressings, they wouldn't be able to tell you if the shoe is tight. And therefore, often as a podiatrist, I've seen patients come back with wounds that have been caused by bulky dressings and the shoe therefore being too tight and causing friction. So you've outlined some really key benefits from obviously the ConvMax dressing. Do you have any patient case studies to share?
Yeah, so we've had some we've got some quite interesting case studies actually. The first one that I can talk to you about is a gentleman who has been seeing us for quite some time. He's 68 years old. He's an amputee, so he had his right leg amputated about 5 years ago, and he developed a wound on his left heel. So this wound has been quite long standing. He's got an edematous left leg as well. So, you know, we found controlling sort of the exudate coming out of this wound to be really quite difficult. The peri-wound area was constantly macerated. We might get it dried up for a bit, but then it would macerate again. He was getting infections because it was so wet. So we were kind of struggling with it a bit. When we got the ConvMax to try, the difference was quite marked quite early on really in the process. So initially we used the ConvMax with an Aquacel AG Extra Plus because the wound bed was slightly sloughy. The first dressing change, which I think was 3 days later on the slide, is, you know, you can see quite a difference already. And then when we came to do subsequent dressing changes, each time you could see the maceration had decreased around the wound bed was looking healthier, and it was just generally a better looking wound. So the second case study that I can talk to you about, it's another gentleman who's had an amputation. He's 71 years old. He'd been coming to us for quite some time with a diabetic foot ulcer underneath his heel. We were sort of struggling to work out a little bit why we couldn't get this wound to heal. And it turns out that it's because he uses his foot to propel himself around in his wheelchair. So there was lots of pressure going through this heel. The dressings that we were using, the traditional foam dressings, were soaking wet. They were acting a bit like the sponges that I mentioned earlier. Exudate was kind of squeezing out everywhere. So we changed him to the ConvMax dressings along with the Aquacel AG Extra Plus again. The dressings that we chose for him were they were 10 by 15, so we could sort of go underneath the heel and then up the back of the heel as well and fix it in place. And he obviously trying to encourage him not to push himself around with his heel as well. But we found that, again, the wound started to dry up really quite nicely, quite quickly. The peri-wound area became much more healthy. So these slides are from just a few months ago, and actually this area that you can see on the picture has gone on to almost completely heal now. So it's done a really good job with this gentleman.
Thank you. That was two really great cases. So any key takeaway messages from those cases that you've shared with us, or patient feedback, any impact to them?
Yeah, the patient feedback we've had for the ConvMax has been really good, actually. I know we've sort of said that with a patient with neuropathy, they can't necessarily tell you that the dressing is comfortable, but they have said that they found them a nice dressing to wear. They've stayed in place nicely. Like I said, they've not sort of come apart, which some dressings can tend to do. We actually had two patients earlier on when I started using ConvMax. One was my patient, one was seeing some other colleagues, but they liked it so much they just went straight to their GPs and asked for it to be put on the repeat prescriptions, which, you know, is a good indictment of what they thought of the dressing, I think. So we've had some really positive feedback, and I think my colleagues would agree that it's been a really good dressing to use. Some of the other super absorbers that we've tried in the past were just not really conformable enough around a foot, and so it's been great to have these that we can use on the foot. Like I said, exudate management we know is really important, and it's something that's we're really trying to be better at, and we can do with these dressings that fit on our feet better. I think sort of for other takeaways, I'd say that reassessing your wound every time you do the dressing change is really important. It's relatively easy sometimes to get stuck in the same dressing regime. Thinking when you use the super absorber, you might need that primary dressing in there initially, but take it away and use the super absorber for what it's there for managing the exudate, and you still get some really positive results. Or I have anyway. I found it really good. I think that I asked a colleague actually yesterday if he had any sort of top tips, and he sort of said, make sure you pick the right size. So on a foot, sometimes it's a little bit tempting to use quite a small dressing so that it fits within that patient's footwear. But don't be tempted to, and particularly with a super absorber, you want it to do its job. You want it to be able to wick all that exudate away. So make sure that you're choosing the appropriate sized dressing for what your needs are, really.
That's great. And just finally, we talk about protocols of care and the great work you and your colleagues are doing as podiatrists, but within these patients and diabetic foot ulcers, do you have other sort of teams you work with and carers, or do you have patients' involvement themselves?
So the other teams that we work with, obviously, in community, we've got district nursing who we work alongside, so they're doing a lot of dressings as well. We've got good links with our local, the vascular consultant, the vascular teams. So they'll have sometimes suggestions for us, but they're really happy to sort of hear things from us as well. And obviously the multidisciplinary diabetic foot clinic. We do try and involve patients in their care as much as we can, because we know that the more you involve the patients, the better the relationship, the better it's going to go going forward. So we do have some patients who maybe would be coming to see us multiple times a week, but actually will manage their dressing, a dressing change or two themselves at home, and just coming to see us for the sort of the debridement part and to have a sort of a reassessment. So we like to get the patients involved in their care, and the same with the carers as well. As I mentioned earlier, carers are dedicating a lot of the time to the person that they're bringing to clinic, but they don't want to be bringing them to clinic if they don't have to. So some carers will change the dressings themselves as well, and they're very good at feeding back, saying, oh, when I took the dressing off this time it was really wet, or I took it off and it was dry, or it was stuck. So we sort of try and encourage really collaborative working between us all for the best outcome for the patient.
So based on our discussion this evening, Lindsay, from a podiatrist perspective, you've clearly outlined the challenges of patients with diabetes who have a diabetic foot ulcer. You've outlined from a wound-centric point of view that Exudate, one of those barriers to healing, that we know the importance of managing that maceration. I think one of the key tricks here is that moist wound environment, not too wet, not too dry. The anatomical alignment of these wounds on the foot is a challenge. And you've given some, great insights into how you select your dressings and how you manage these patients. But any final recommendations or top tips to share with our audience this evening?
I mean, something that I would always try and remember is that you're treating a person at the end of the day. You're not just treating a foot with a wound. So really get your patient involved in their care. Inform them why you're doing what you're doing. You sometimes get the feedback from the patient that all you're doing is putting a dressing on it, but actually what you're doing every time they come in is you're assessing that wound, you're assessing what that wound's needs are, what that patient's needs are. So really keep your patients involved every step of the way. And medical care or patient care now is really going more towards them being really involved. So you're not taking the whole burden as the practitioner. You've got that patient sort of cooperating with you. And the patient's family as well, because if the patient's happy for you to get the family involved, if any family members come to clinic, get them to have a look at the wound. They can see how it's progressing. Lots of patients now take photographs, so they'll ask to take a photograph when they come into clinic. So they are really more interested in their wounds than they used to be. Years gone by, lots of patients didn't even want to look at their foot when the dressing was being changed. That's certainly not the case now. So yeah, absolutely, I'd say just be aware that there's a patient sat in your chair, another person, and involve them as much as you can. A tip, again, when I spoke to a colleague yesterday, and I sort of said, have you got any top tips? And it's slightly away from what we've just talked about, but he said, if you're dressing a foot, make sure you've got everything ready before you get going. Feet are quite difficult to dress. You feel like you need sort of another 10 fingers helping you to hold things in place, particularly when you're using tapes and things. So if you make sure that you've got your stool set out before you go, and again, you can get your patient involved if they're flexible enough. Sometimes they can hold things in place for you, help you with your bandaging. So it's just a little aside. It's something that's really helpful. Get yourself organised first before you get started.
Yeah, I think that's great, Lindsay. Thanks so much. And your sharing your insights and your experience has been incredibly informative this evening. And you've really clearly identified those challenges and the success you've had with addressing that's managed those challenges for you. You've been able to display and demonstrate the importance to you as a clinician, but also most importantly to the patient. So thank you so much for taking your time this evening to talk with us on this very subject.
Yeah, thank you. Thank you very much for having me.
So now we're going to move to a Q&A.